goes to two domains. First, eye rubbing, and because of laser vision correction procedures weaken the cornea, the laser vision correction procedures do take a lot of duty in the pathophysiology of ectasia after refractive surgery. But the major concept is that any cornea may develop ectasia if it's weakened beyond its limit of resistance, let's say like that. So if you want to avoid it, this is a general public awareness campaign. But if you understand this little message here in a more complex domain, because eye rubbing or stretching the eyes, sleeping over the eyes, aggravates keratoconus and may also cause ectasia. Those are different things. So here we have a huge complexity because we have a very keratoconus is an ectasia, but eventually not all keratoconus-like cases that we see at the clinic are true genetic keratoconus. But eventually it's not one or the other, it's a conundrum and a continuum. And understanding risk factor for LASIK has given us a lot of opportunities to evolve. The contribution from Brad Randeman took into consideration topography as a kind of a surrogate of corneal structure. And form fruus keratoconus is here as 4 in his scale, which is a weighted risk stratification scale for detecting ectasia risk. Age is a surrogate of biomechanics, but it's not a specific surrogate because you can have a patient with 19 years old with a strong cornea and a patient with 41 years old with a relatively weak cornea, as I will show to you. So it's important to understand the literature and the experience from others. 300,000 LASIK procedures reported by Steve Schallhorn. You can get the green bars here are ectasia cases. So 30% of ectasia cases in his series had a normal topography and tomography. And about 1% of the stable LASIK cases with a long follow-up, these cases had a relatively abnormal topography and tomography. You see the back elevation and the thickness profile in this case. So what is form fruus keratoconus? Form fruus keratoconus is hard to define, and a very nice systematic review that was published in the JRS demonstrated that there is no agreement on the definitions on form fruus and subclinical keratoconus in the literature, in the published literature, in the English published literature in PubMed. Form fruus relates to an incomplete form of the disease that may progress or not to the full-blown disease. Form fruus is not exclusive to keratoconus or ophthalmology. Sigmund Freud, detected form fruus psychosis and neurosis. And eventually, if you read a little bit about Freud's work, you can detect form fruus diseases in the minds of some of our colleagues. Mark Hemsler looked at keratoconus as progressive, natural progressive, with a photokeratoscopic, with no topography, computerized topography, that was just photokeratoscopy. And he would say that this patient has a form fruus because he progressed to the full-blown disease. Yaron Rabinovitz, who is very much related to the development of corneal computerized topography since 1989, when he was finishing his fellowship in the West Coast in the United States and in California. He did a great work on understanding the asymmetry. And his classification of form fruus is when you have normal slit lamp and abnormal typical keratoconus topography. Like this case, a patient with 20/20 normal slit lamp and inferior stiffening with a higher asymmetry in the AS value. So topography gives you ability to detect disease in the right eye of this patient, but not in the left eye of this patient. So it comes to the asymmetric cases, the very asymmetric cases. And the term unilateral here is very much disputed by my concepts of understanding the disease. This left eye gives us the opportunity to look for other data in terms of corneal shape and structure so that you understand what is not normal in this normal looking topography cornea with 20/15 vision. And in the editorial by Kleiss in 2009, in the British Journal of Ophthalmology, he, in his brilliant Chasing the Suspect keratoconus, he would say that this case is a form fruus keratoconus. Damian Gatinel has many contributions in this field, and we have this cartoon for him. And I would say that the overlapping here of keratoconus and normal is much more neglected here because he's talking about topographic criterion. If you say this line will be the absolute truth, I would say this will be correct. But if you talk about topographic criterion, you have much more overlapping, and the concept of suspect is very much doesn't help much because everybody is a suspect. I don't need to do any exam to say you were suspect. And we have to do the exams to say which suspect should be the cases that we should be aware of and worried about. Topography is important for screening, and there's no question we have to go beyond it, but not over it. There is no consensus on what is form-fruit keratoconus. It's a fact. And my humble contribution to the field is that we consider form-fruit keratoconus a patient with a very high susceptibility for ectasia progression. And we came to that in 2009. A few years before that, we started this theoretical idea of understanding susceptibility. But when I saw this patient was very much important for this understanding because the patient had LASIK in the left eye and no surgery in the right eye. The left eye evolved ectasia. The right eye would qualify for LASIK based on topography, front surface topography with placido, and central corneal thickness around 528 microns in the center of the cornea. We published in 2010 the Pentacam and the Riker ocular response analyzer. Abnormalities, here the hysteresis of 8.6, lower than 8.8, and CRF lower than 8.5, 7.5 here in this case. You have a D in the yellow range. This is the second version of the Bell-Ambrosia display. So this patient is a susceptible cornea in the right eye. This is another case. This case will give you a lot of information because we learn that many colleagues, when they see the post-op, they will say, this little yellow thing here will be a pathognomonic form-fruit keratoconus finding, as I heard in a meeting. This case was sent along with 25 others to colleagues that are experts, 11 colleagues, and they were asked to do the classifications. These classifications were also asked to be done with the same cases, not necessarily the colleagues knew they were the same cases, but with a different scale. Interestingly, they had the Randleman score as the classification, and we had a significant variation among examiners. With the first scale, the classifications vary in each case from 0 to 4 in 68%. And the second, it varies from 0 to 4. It means that one guy says it's 0, the other one says it's 4 in 44%. So about half of the cases, the classification varies from normal to absolutely abnormal. And the classification between the two scales were significantly different in 9 out of the 11 classifications. But going to that case necessarily, the mode will be 0, even though varying from 0 to 3 with the first scale and 0 to 4 in the second scale, but the mode will be 0. So if it's a democratic refractive surgery environment, this patient will be considered as a candidate for LASIK, and the patient would have LASIK. We know that the patient had ectasia, and we need to understand the susceptibility in a simple way, not simpler way. It's important to understand elevation is not easy to be understood. You need to understand the reference. You need to understand best fit sphere, toric ellipsoid, float. All this is not easy. And Michael Bellin came to a very nice contribution with enhanced elevation, in which you exclude a zone to calculate a best fit sphere, and you compare with the first regular standard best fit sphere. My contribution is that spatial profile of the thickness, as thinning is a hallmark of ectasia, and you can understand a thin normal cornea and a thinned abnormal cornea. So time is important, time and space. And here you have the graphs that you have the average of the thickness within each of the circles, and here's the percentage of increase starting from 0. The combination is the Bell-Ambrosia display, and the D is a logistic regression analysis so that you can get the information in a more complex and very simplified way. And here you see that this is susceptibility for that case. We have to go beyond, but not over. Beyond 2 factors, detecting keratoconus. We are not detecting keratoconus, we are detecting susceptibility for detecting keratoconus. And also we have to go beyond front surface topography. This is a case that had SMILE and developed ectasia. And you see the abnormalities in the Ds here. This patient was sent to me, and I was able to say even the front surface topography was abnormal. And I bring this case to you because it has a very interesting factor. The keratometric maximum value is 44.6 in the right eye and 43.9 in the left eye. So this is low keratometry keratoconus. This is not fruit, this is not subclinical. It's actually subclinical, but it's not something different than keratoconus, and it's low K keratoconus, which is something we see in about 8% of keratoconus cases. So the conundrum of ectasia, which goes beyond 20 years now, give us a lot of important information. Last year, we had a very nice publication with 30,000 laser procedures, 10 cases of ectasia, and these cases were hard to be detected in terms of risk factors. 3 out of 10, 30% residual stromal bed lower than 300, 2 out of 10, 20% PTA higher than 40. In all these cases were considered to have normal topography pre-op. We have our series of 3,200 cases versus 105 ectasia cases, and you see age, PTA, and residual stromal bed. You see IS value is very specific because people obey the fact that we should not do surgery in patients with asymmetry. And this is very important to be understood. Now it comes close to what we should talk about, which is enhanced screening with the TBI. This is a study that has taken into consideration objective parameters, a population of disease and no disease that is different. And the PRFI, which is a Scheimpflug-derived random forest parameter, would give you the improvement in accuracy. You see the bad D is better than the AS value, but now we have a better parameter. And the brain would calculate along with the relational tissue altered, you have the understanding of the properties as a necessary thing. And this comes to the biomechanical domain. I will give you the information about Ricardo Vinciguerra work, and I'm sure Ricardo will go and elaborate more on the CBI, but we need to go from this beautiful cartoons on the Corvis so that you understand then the data about the cornea structure. And the CBI that awarded the Trautmann Award with Ricardo Vinciguerra in 2007 gives you a better understanding of the cornea structure and biomechanics. We need to evolve to combination of shape and biomechanics, and that's the work we've done in our study group. Pentacam gives you topography and tomography. You have the Scheimpflug-derived deformation metrics, and for having higher sensitivity, we need to go for the normal topography cases. We have some studies done on normal topography eyes of twin cases that have keratoconus. We have the fellow unoperated eye from patients with ectasia, and in terms of specificity, we have to consider the patients that had the surgery and were stable, and eventually do evaluations in more complex ways in terms of patients in longitudinal fashion. So the 96 cases normal topography were defined as normal topography based on very strict criteria, and this was used to be trained along with my cases and Paolo Vinciguerra cases from Milano, so that we have these cases for training the ARV, which is Ambrosio, Roberts, and Vinciguerra display. And the random forest with vivo and out cross-validation was the best method for the combination. And here you have the dot plots of these cases. The dot plots will give you the sensitivity for subclinical case that has to be optimized on 0.29. It's important that we understand that clinical implementation should be taken after validation. So we did a validation in our series and found pretty much the same cutoff with a relatively same distribution of the cases in patients from my clinic after the TBI was conceived. So some of these cases, as I presented, will be much more clear to be seen if you integrate the data. So now is 41 years old patient, the patient that's stable that I reported in 2010. The PRFI is 0.19, the BAD-D is 1.37, and if you look at the TBI is 0.78. And this is clearly a weak cornea. It's a susceptible cornea. We have the patient's son. The patient's son has both eyes, normal slit lamp, 20/20 distance corrected, moderate allergy. You see a TBI of 0.52, 0.63, and this is what I consider as bilateral fruste. Another interesting case, the patient is a twin sister. The first twin comes with a very asymmetric ectasia, similar curvature maps from Scheinflug and from Placido. The TBI is abnormal in all the 4 eyes, including both eyes of the twin sister, with both eyes with a normal topography. We are aware of the cases that have abnormal, that have very asymmetric topography, very asymmetric ectasia with normal topography, and the sensitivity in the literature in some of the reports are very low, considering what we published in the first studies. And once we have these cases, we are highly select. Some of the series are highly selected with normal topography and tomography, and eventually novel biomechanics as well. So they are selecting cases that are the ones that are normal, as we as we already were published. But we get the opportunity to improve. The opportunity to improve is something that we did in a very large series, including 25 international centers. And we have an impressive 543 very asymmetric ectasia cases with normal topography. So we can improve the training. And you see the bad deed is good to detect the clinical cases, very good actually. It's the best parameter. It loses a little bit to the PRFI, but the accuracy for detecting normal topography eyes is lower. So we have machine learning algorithms, the very asymmetric ectasia, normal topography cases, and the random forest was the best parameter. And here I present you one of the parameters that are with the best accuracy. And if you see, even for the clinical cases, we are talking about keratoconus case, when I randomly select from these cases, and the ectasia case that was not operated from these patients, you go from a little, you have a little bit, you have a half a point of improvement. But if you see, it's a 10 points improvement in sensitivity with a better cutoff. The cutoff comes from 0.29 to 0.4. So it means that artificial intelligence can evolve as anything in our lives. So we are in this planet to evolve, and our intelligence has to evolve, and the artificial intelligence that we create, we should evolve too. So it is something we have to acknowledge, that it always has to be to gain. We don't want pink cases down here, which means that TBI classic first version is higher than and normal for the new parameter. So we have abnormal cases here, and we are looking into 2 situations, and it comes now the point of the concept of ectasia versus keratoconus. This 27 years old, let's say this eye, the right eye of this patient is 2015. This patient has a normal tomography. Let's see the biomechanical data. It's abnormal. It's one of the cases that CDI is very much abnormal. You see the stiffness parameter at A1 from Cynthia Roberts. The fellow eye of this patient is a mild keratoconus. Interestingly, the combination of data improves you the accuracy to detect susceptibility of ectasia in the right eye. And this is a very asymmetric ectasia with normal topography, but a form fruste keratoconus. The consensus is that keratoconus is a bilateral disease. True unilateral keratoconus does not exist. And I love Star Wars, and I come as the main wisdom from Master Yoda. But also, as the General Council of the Jedi would say, secondary ectasia can be unilateral, caused by a mechanical process. So this is the case that we present. This patient developed ectasia in the right eye naturally and comes to me for surgery, and we did a ring, and the patient did beautifully. One beautiful work from the ring. You see 0.2 diopters of astigmatism. This patient moves to London, and I have him follow up by Dan Reinstein with a normal epithelial thickness in the left eye that presented and is still stable with a 20/20 plus uncorrected vision. Other shape factors like the Myung-Gatinel and Lanside score are also normal. So we published this case in the Journal of Ectasia and Keratoconus. This patient comes back a few years later, and the TBI is 0.02, very much stable in the clinical fashion. So corneal tomography and biomechanics is important to early screen and early diagnosis. They're not exactly the same thing. We have to understand what is screening and what is confirming the diagnosis. It's important to understand what is the diagnosis and prognosis, classification and staging. Detailed follow-up is fundamental for teaching patients, for helping us make the decisions for these patients. And of course, all this data, including the multimodal imaging like wavefront and axial length, will be important for treating these patients. Enhanced refractive surgery, we should understand what we are trying to look for, understand the enemy, understand what we have. And what we have should be multimodal imaging. And in terms of your clinics, if you don't have all these fancy tools, understand the limitations and go in the level of more secure procedures like surface ablation for these patients. AI is important. AI is going to be part of our lives more and more. And I think AI should be understood how to work and live with that in the best way as possible. Enhanced susceptibility and biomechanical impact are going to be improved by AI. Postoperative, eye rubbing is very bad. We should tell people not to rub the eye. And the concept of going beyond but not over. I have a new tomography. I have now Bowman's layer curvature. Forget about everything. That's a mistake. We have to go beyond what we have to improve, but not neglect the good work that was done, in which we grow upon their shoulders. And that's true revolution in evolution. I welcome all of you to join the campaign. I remember well a couple of years ago when Damian Gatinel visited Roy Shetty, and I learned that the no for you in India is balancing the head on the sides and telling people not to rub the eye. And I have this video here that should be promoted more and more. So we tell people not to rub the eye. It's an important message, and we can improve our understanding with keratoconus if we understand that eye rubbing can aggravate keratoconus and cause ectasia. Finally, we had high expectation for the 2020 year. This will be the year of ophthalmology. Unfortunately, we had this crisis that is taking all the planet. And the month of June is even going to be more important than what we ever imagined for our campaign, because it's the month that we're looking forward to the new. And violet is also a very important color because it means healing, transmutation, so that all the concepts that we need in this difficult times. I hope all is well for everybody, and I look forward to having you join the Violet June campaign, and just post in social media, don't rub your eye. Let's consider the Violet June campaign for keratoconus awareness. Thank you very much for your attention, and I look forward to good discussions and to enhancing collaborations in our future. Thank you.
Thank you, Dr. Renato. I think that was a very extensive and comprehensive talk on the TBI, the Scheimpflug tomography, and the biomechanics for screening of refractive candidates. And I think those examples were great. They just help you to understand how it is going to, how it goes. Next, I would like to invite Dr. Ricardo Vincigura for his talk on corneal biomechanics evaluation after cross-linking.
Hello, can you hear me well?
Yes.
That's good. So I'm going to share my screen. That's it. Can you see the presentation?
Yes, yes.
That's very good. So actually, they asked me to present two talks. One is about the cross-linking effect measured by the Corvis, and then the evaluation of corneal biomechanics after refractive surgery. I would like to apologize for being late, but we were catch up in longer surgery than expected, so I do apologize for being late. Okay, so I am going to, well, this is my financial disclosure. I'm happy to be part of the Oculus family since a few years. And I think it's very important, before we speak about cross-linking and how to measure the effect of cross-linking, to speak about IOP measurement. But why is this the case? The Corvis is a tonometer, and all tonometers are based on a very simple concept, which is you apply a force to a ball with an internal pressure, and then you evaluate the resistance to deformation, which is dependent on pressure. And you correlate the deformation to pressure. while this concept is correct, and high pressure causes small deformation, low pressure and causes large deformation. But it's also true that large thickness will cause small deformation and stiff material will cause small deformation. At the same time, small thickness will cause large deformation and soft material will cause large deformation. Why is this so important? Because we can have the same deformation, which will be seen by the Corvis, that we have to remember it is a Scheimpflug camera with a non-contact tonometer, and that can be caused by a small pressure and a stiff cornea, or a high pressure and a soft cornea, or any combination. So it's difficult if you don't do anything before to separate pressure from stiffness. So at the beginning of our journey, we were first measuring pressure, then thickness, and then biomechanics, so we had to work on this. So the first step we did before going to the CDI, the TBI, was to evaluate the normative values with regards to pachymetry and intraocular pressure. And this was done in 2016. At the same time, Professor El-Sheikh from Liverpool University, where I had the pleasure to work for a few years, developed a new equation that is called BIOP, sorry, that is able to compensate for age, because we know that the cornea over time gets stiffer, pachymetry and biomechanics. So this step was very important, because if you then know how to measure correctly intraocular pressure, then you can finally evaluate the corneal biomechanics and then diagnose for keratoconus. So we proved that with the CDI, that is a combined index based on biomechanics, we were able to separate very effectively healthy and keratoconus patient, and also it's good in subclinical cases. As Renato has said, we were very proud to receive this prize by the American Academy and the International Society of Refractive Surgery, and this is actually an honor for the whole group. But now we need to speak about cross-linking. If we speak about cross-linking, we speak about stiffness. And I like to start, as in the Bible, in the beginning, there was stress strain. So when we started cross-linking back in the early 2000s, we were measuring the corneal stiffness actually by pulling the cornea. Obviously, this we cannot do it in vivo. So what did we do so far? Well, in the first months, it is known for everybody that is doing cross-linking that the pachymetry gets worse, visual acuity gets worse, curvature is worse, and aberrations are worse. So if you're used to work with cross-linking, and maybe you have also residents working with you, they will come to you asking for help. They will say, Dr. Vinciguerra, what did you do? The patient is worse, the curvature is worse, maybe we have to do cross-linking again. And then you go to them with the knowledge that they will get better, say, don't worry, because best corrected visual acuity, seen case, aberration, they will get better over time. But the reality is that you don't know. This is just an average. There are some patients that will not go in this way. Then we started evaluation the demarcation line. The demarcation line is a whitish line that we see in the anterior segment OCT. And then we know that it's correlated with the depth. Is it correlated with the effect? Not really. There are some studies, particularly this one that is very nice, published in Graves, that showed no correlation between the depth of the demarcation line and any of the parameters that we evaluate after cross-linking, such as visual acuity, change in Kmax. So if the demarcation line is deep, that does not mean that the patient will go well. So why don't we go to basics? This is what I thought a couple of years ago when I was working in Liverpool. Biomechanical assessment, what we need. And this is what also Renato showed. We are both fans of Star Wars. So as you can see, we do like using this figure. But this is to show you that if we are stiffening the cornea, why should we measure something else rather than the stiffening? So this is what we do. We use the Corvis ST. And I'm not sure if Renato showed you in details the phases of the cornea, but I think it's worth explaining. So what we do is we hit the cornea with an air pulse. The air pulse will deform the cornea. So first the deformer will go from the convex case, when it's naturally convex, to being applanated, then it will get concave, and then it will go back. From this measurement, we can have many parameters. It's very important to know that the shape parameters, meaning the curvature of the cornea, rather than the deformation amplitude, are very much correlated with the biomechanics. So we wanted to see, in the first month, are we able to see a change in corneal stiffness, which we were not able to see with the ocular response analysis? So we did a very simple study. We took 34 eyes, we did AP-off cross-linking for progressive keratoconus, and we did the corneas and pentacam the day of the surgery and 1 month post. It's very important that we stop for one moment. There has been some studies after hours in which they said we cannot see this effect. It's important to explain that if you do not do the corneas and the day of the surgery or maximum 1-2 weeks before and 1 month post, you will not see this. So if you do the corneas 3 months before and then 3 months after, you might not see the change. And this is because the changes in corneal stiffness are masked by the changes in viscoelasticity. So do it in the week of the surgery and 1 month post. So our result is that we were able to see a significant rise in stiffness. This is demonstrated by an increase of stiffness parameter that was invented by Cinzia-Roberts, which makes sense. If the stiffness is higher, the stiffness parameter will go more and higher. And then we have a decrease of inverse concave radius. Actually, it's inverse integrated radius. Let's stop with this one. So you have to imagine that if you have a cornea that is stiffer, it will deformate less. But also, the shape of the concavity will be smaller. So it will be more flat. If it is flatter, then it means that the radius of deformation is smaller, is bigger, which means that if you do 1 over the radius, it means that when it gets stiffer, the inverse concave radius will get smaller. I know it's complex to remember. We usually describe the inverse concave radius because when the cornea was softer, the inverse concave radius will go higher. So, as we said, the beginning we measure stress strain, but that was measured in ex vivo, sorry. So now we are finally able to measure the stress strain in vivo. And this is a new study that I want to show you. It's a very complex index that we published all together in collaboration with Liverpool University. So basically, if you are aware, if you know how the stress strain curve is, as you can see, normally this is how it is. It has a very strange shape. So it's impossible to describe the whole curve in one point because this point has a different shape and slope compared to this one because it's based on the stress. What we did is we created an index that is able to describe the whole curve, and this is the stress strain curve. So we have seen that the stress strain index is correlated with age, which is good because obviously if it is correlated with age, then it means that it's correlated with the stiffness because we know that stiffness gets higher over time. It's independent on IOP and independent on thickness, which is also good because if it is stress strain, which measures the exact stiffness of the cornea, it should be independent, on these two last ones. So if we have the stress strain index and the cross-linking, we should have an increase. So we did 2 experiments. One, we evaluated the patient pre and post cross-linking with stress strain index, and then we evaluated if the stiffening effect is correlated with the flattening. This is still ongoing. But the first one, we had very good results. So we have seen that the stress strain index was significantly changed after surgery. This is still unpublished, but we're going to publish this very soon. So we have more and more evidence that we are able to see the change in stress strain after cross-linking with an air pulse tonometer. And this is the unpublished data, seeing that we did see some correlation between the change in stiffness, meaning when the cornea gets stiffer, we have also seen that the Kmax gets less. I think I do see some question, but let me finish and then we will stop for question if you want. Let me show you something in clinical practice. So why is it important to do another study? As you can see, we worked a lot. If you want to know if a cornea gets stiffer over time, you need to know how much is the noise. What does it mean? If you do two measurements of any kind, even how tall is a person, but you don't know how noisy is your measurement, you don't know if this person, you see it in 2 different months, if you see a difference of 5 centimeters, but your system is very noisy, you don't know if that change is significant. So the first thing we did is we have seen how much noisy was the measurement of biomechanics. And with that, we were able to create a confidence interval, which means that we know that if it gets stiffer more than that, it means that it's significant. This is how it looks, for example, in the display that I will show you in a second, the change in biomechanics. So this is the stress strain curve between B and A, so 2 different time points. And here you can see that it's stiffer because it's higher than 2 standard deviations. And this is how it looks. So this is the biomechanical comparison display, which is available on the Corvis software. You see Corvis at November and December of 2011. You can see that deformation amplitude ratio, integrated radius, stiffness parameter, and stress strain index are all getting stiffer 1 month after cross-linking. And this is how it looks, you see? So this is pre and this is post, which means it's stiffer. Now I'll show you a very nice case report that was given with courtesy of Dresden University. So this is a patient that got worse before cross-linking. But let's see biomechanics. You can see that also the cornea in this case got softer, which does make sense. So there is significant softening before cross-linking. And then you do cross-linking, the cornea gets steeper, as we expect. And post cross-linking, you see that the cornea gets stiffer over time. And guess what? After 6 months, you have a flattening of the cone, which is in agreement with the previous stiffening. So in conclusion, biomechanical comparison display will help us to follow up patients, for example, in keratoconus, post cross-linking, post intracorneal links, and after laser vision correction. And the stress strain measurement will help us to understand the intrinsic material properties of the cornea. So I will stop now because I think this was very dense already. I do have another talk that I should give, but maybe there are some questions which I'm happy to have.
So thank you, Dr. Ricardo, for your talk. And there are some questions. Dr. Mahipal Sachdev, sir, would you like to ask questions which are there on the panel? Sir, you have to unmute, sir. Unmute, please.
So there is a question which says, could you please explain again what you meant by the need to do the Corvis on the day of the surgery and then a month later, because the results would be masked if you did it 3 months earlier and then 3 months post-op. So
yes,
one second, there's still more to it. He says the reason I asked is that if this evaluation is meant to see the effect of cross-linking, wouldn't the effect be expected to persist long-term post-op?
Yes, so this is a really excellent question. So I can reply on this question by, let's say, in 2 ways. So the first one is experience. So what we have seen is that if we do the measurement many months pre-op, so let's say 2 or 3 months pre-op, our experience is that the cornea gets softer in the meanwhile. So that means that you have a cornea that is here, it gets softer, then you do cross-linking, but you don't measure it, then it gets stiffer, but then you don't see the difference because it got softer, then stiffer, and then you don't see the difference. With regards to the second part of the question, which is you should expect to see it long-term. Yes, this is what we thought, but in a way, we do not measure pure stiffness. We measure, there is always some part of viscoelasticity. So what we think is that after some time, there is remodeling, and the remodeling, they masks somehow the measurement of corneal biomechanics. So this is experience. I do understand that it will be better to have this over time. But so far we have seen that if we do not make the measurement more or less close to the surgery 1 month post, you're less likely to see a change.
Okay, and then they ask how Corvus measures stiffness. Means is it automatic or can it be manipulated? And the second part to the question is, does dryness make a difference on this measurement?
So dryness does make a difference for 2 reasons. The first one is because sometimes when you have also dry eye, sometimes the epithelium is slightly hazy. So that can cause an alteration. So if it is not extreme dry eye, it will not cause a problem. If it is extreme, yes. And sorry, the first question was?
How Corvus measures stiffness. Means is it automatic or can it be manipulated?
So, well, stiffness is a big word, meaning that all the measurement of the Corvus are done automatically. So everything that I discussed is automatically available in the software. Of course, there are a lot of researchers like us that we do work on the pure parameters of the cornea or the Corvus or shape. But that obviously is something that is quite advanced. So for the normal user, that is not needed.
I have a question for Dr. Renato. Dr. Renato is here. You mentioned something about low keratometry keratoconus. So what do you think is the incidence of low keratometry keratoconus, and then how do you distinguish it with the subclinical keratoconus?
I'm not sure whether he's there.
No, I think
Dr. Ambrosio or
anybody can answer the question if Dr. Ambrosio is not there.
Rohit or Dr. Ricardo?
You want to reply, Rohit?
Yes.
Ricardo, you can do it. I'll present it with my slides.
You sure?
Yes, please go ahead.
Okay. So, well, I think that the keratometry is just one part of what we see. So the definition of ectasia has 2 definitions. First of all, we should have an increase of curvature together with increase of elevation and decrease of thickness. So having a low keratometry does not mean that the keratometry is normal in general. It means that it's not as high as we do expect. Another thing that is important, ectasia is coming from a Greek word, which means progression. So ectasia does progress over time. So you can have a keratoconus that is at the beginning. So the keratometry will still be low, but it will get worse over time. So it will be still a low keratometry keratoconus, but it will progress over time.
And there's another question for Dr. Renato. He's not there, so you will have to, if he's there, then he can answer. If you have one investigation to diagnose ectasia, what would be that one investigation that you will rely on?
I think that we have to differentiate, because I know that we like to be on as simple as possible. But the point is, I don't think that we should say what is one thing, because if it is one thing, it's like saying, if you do it's like saying, let's say that you have a patient that is coming to you to do a visit, and they say, would you prefer to do visual acuity or see the patient at the slit line? You need both. You need both. It's the same thing. So I think that if we are proving that biomechanics is helping tomography, then we should use both. There is evidence that also epithelial maps are very good. So obviously, it's not mandatory to have everything. I think that it's mandatory for sure to have tomography. I will reply to the normal values of CBI and TBI in a second. But I think we should aim to have everything that we have evidence enough that is useful, and not say what is the only thing that we should use. We should try to have the best for our patients. I've seen a question regarding what are the normal values of CBI and TBI. So the cutoff of CBI is 0.5, as simple as that. And it's very unlikely that the patient will be in between. So normally they are 0.1, 0.2, or 0.8. You will have very few patients in the middle. TBI, the original cutoff was 0.35.
Okay, there
are some studies that showed a little bit higher, a little bit less, but it's always around that cutoff.
So there's another question which I don't know whether any of us will be able to answer. Our Bangladesh, so there are people listening from Bangladesh. Our Bangladesh area has very few doctors who have started biomechanics tests. So my question is future market in Bangladesh area. So I don't know any advice from your side. So how important, maybe we can reshape it, that people in our neighboring country, that is Bangladesh, don't do biomechanics studies at all. So according to you, is it something that is mandatory? It must be there, or they can still continue to do the refractive surgeries?
Hey, this is a very difficult question. There is evidence that biomechanics is better. That's for sure. But it's like saying, let me reply in a different way. I think we all do know that there are some lasers that are more effective than others. Is that correct? So we do know that, for example, I don't know, I don't have any financial disclosure, so can I say that? Like the last shrink is better compared to a shrink that has 10 years. Everybody knows that. But is it mandatory to have the last one? This is up to the surgeon. If you feel comfortable to work with an old shrink or an old Visex, that is up to you. But you should know that there is something better. It's not mandatory, but it's up to the surgeon. There is evidence that the evaluation of biomechanics together with tomography is better than tomography alone.
Okay. Thank you. I think there is Kripal or somebody, Webin admin or anybody else, they want the YouTube link. One person is asking, so I don't have the details, but it is on YouTube. If Kripal, you are there, if you could share the YouTube link also.
So, Dr. Tityal sir, would you like to ask some questions before we go to the next presentation?
No, nothing to ask as such. It was a great learning from both the talks, as far as the last question was concerned from Bangladesh, I think looking into the number of cases which may develop ectasia after refractive surgery may be very low. But the science is progressing, and refractive surgery is such a surgery where we don't want a single case with complication. So I think biomechanics is going to be a part of workup for a future refractive procedure. So we all have to work on that and get this thing implemented into your clinics.
One question I had, and that is all the parameters that are being given to us are, on a subset of patients, at least for us in India, which is not Indian. And we are extrapolating those values, whether it is CBI or it is TBI or, it has been pentacam values, bad, or whatever those parameters are. So how much do you think these ethnic differences will actually, be there vis-a-vis the geographical location and vis-a-vis the population? Because as far as our own population is concerned, we probably have not generated the standardized data.
Yes.
So you think that there'll be ethnic variations? And Rohit, even I would like to respond, you also to respond to this, and Dr. Renato, if he's there.
I think Renato just replied that he's in the clinic.
Okay.
Just in the chat. Okay. So I think I can reply to this. Let's say that, let's reply in two ways. So the first thing we should acknowledge is that when we created the CDI and the TBI, we did not include patients from Asia. So that was a limitation, and we did write that in the study. The good thing on the other side, though, is that many doctors from around the world validated the CBI and the TBI in pretty much all ethnical population. And now, but this is not published, so obviously it's something that you have to trust me, we received, I think, data from all over the world. So I don't think we miss any countries, except of very small ones. And we do see differences, that is sure, but we still see that these parameters are quite robust, which means that you will have some population in which they work better. You will have some population in which they work not as good as, but they are still quite reliable. And I had good feedbacks from Asia. I recently went to Singapore, and I had quite a lot of people telling me that the CBI was working very well, and also from Africa, when I went to South Africa. So also from India. So if you do know some ethnical group in which these two are not working, please do let us know.
Rohit, what would
One of the things which it strongly affects the measurement is, Ricardo mentioned in the beginning of his slide, is intraocular pressure. So if you are looking at anything to do with biomechanics, more than your deformation amplitude or deflection amplitude, it is also important that you look at your IOP and correlate it with your IOP. I think that's a very important take-home point for all of us who are using it. A patient with a deformation of X with an IOP of 20 is going to be different from a patient with a deformation X with an IOP of 15. So I think more than okay, of course, I understand that geographically we need, because our corneas are not as thick as the Western corneas. The corneas are really thinner, and we have thickness ranging from 520 to 530 compared to 560, 580. But our intraocular pressure plays a very important role. So making a diagnosis of cornea becoming stronger or weaker without IOP is something which is not to be considered. I think Ricardo will agree, because that was his first slide which he started off with.
Okay, maybe we can move on to the next presentation, Dr. Namta.
Yes, Dr. Ricardo,
Sure.
have your next talk.
Okay. I'm sharing the screen again if it works. Yes, it does. Okay. So this is a work that I'm really, really excited about. So it's a new way to diagnose post-laser vision correction ectasia. We wanted to use the same words, the same title of the CDI. We called it CDI-LVC, like laser vision correction. Same financial disclosure. And I want first to tell you a story. This is how we started. Pretty much everything started back in 2010. And we have been working with Corbis before that. But when really our work started, it was in a room of a hotel in 2010 in Chicago, in which we joined together and we decided that we wanted to be a group and to want to go to work all together. And we have to thank Oculus, because Oculus really helped us in this project. So I showed you a little bit of our journey. So we started with BIOP, then the normality values, the CDI, then the TBI, and then the stress strain. But now we have to move forward. We have to speak about the laser vision correction ectasia. So we do know that LVC is very accepted. But even if the safety profile is excellent, there are some cases that will develop ectasia. And the early detection is as important as it can be, because if you have a patient with good visual acuity and you do cross-linking, they will not progress. It is true, however, that there is no validated index to diagnose an early ectasia. And most of the time what you do, and when you think that is an ectasia, you will see the patient back to see if it gets worse. But then you are accepting that this patient will get worse before making any decision. And ectatic change can happen many years after the surgery. Smile can cause ectasia, and also LASIK extra cause ectasia. So you're not safe with any procedure. You have to be sure. So obviously the first thing is do not harm your patient if you can. So try to be careful and not induce ectasia. But how can we use biomechanics to diagnose this? Well, we think that the primum movens, so the first hit of keratoconus, is a change in biomechanical properties, a focal change. So if it is the same in LVC, that could help. But there are many challenges. Well, the first one is you need to be able to separate normal patient from keratoconus. Then you need to separate stable patient from LVC and abnormal patient. But guess what? There is a problem, because the TBI and CDI are always abnormal in these patients, because the TBI and CDI are made to separate keratoconus and healthy patients. So how do you separate stable LVC from ectasia? You need a very large database. So then we called for help. We spoke with many friends around the world. You can see that there is India, that is Germany, there is Korea, Japan, United States, all over the world. We used the Corbis and we increased the database. This is the biggest database in history. We included, and I will show you in a second. Sorry, we had two aims. The first one was to create an index to separate stable LVC patient from LVC ectasia. And then we wanted to create a semi-automatic approach to even go further. But let's go that in detail in a few slides. Let's start with the first aim, to create the CDI-LVC. We increased and we put 736 patients from different continents, many countries. They were stable patients after laser vision correction, PRK, LASIK, and SMILE, and ectasia cases post-LVC. Ectasia cases post-LVC are rare, but the patients we included were even more rare because they were not treated. None of them had cross-linking. And you can imagine that maybe getting 685 stable patients is easy, but getting 51 post-laser vision correction ectasia was really tough. So stable laser vision correction had at least 1 year of stability, and all laser vision correction ectasia were confirmed by 2 or 3 corneal experts, namely me, my father, and Renato Ambrosio. We used logistic regression, and we used 85 of the database as training and 20% of validation. Let me show you the result of CDI-LVC. These are the variables, but I think we can skip them. I'm much more interested in showing you the results. So this is the ROC curve. Don't panic. The ROC curve it looks difficult, but it's not that difficult to learn. The higher is the curve, the better is the separation. But what you're interested is not in the training data set, because this index was created to separate as best as possible the training data set. What you're interested in is the validation one. And you can see there's a sensitivity and the specificity to separate stable laser vision correction from ectasia is more than 90%. But how does it work in clinical practice? Well, if the patient comes to your clinic, you need to know at least if the patient had refractive surgery. But sometimes this information is not available. Let's say that you have a patient that is old and doesn't know. Or maybe you have problems with language. They don't speak your language. So then we wanted to create a semi-automatic approach to help you even with this. But then there is another challenge, because as we say, all the indexes that are created, such as the BED-D, the CDI, the TBI, the KISA score, are abnormal after surgery. So then you need to separate normal from keratoconus, keratoconus from laser vision correction stable from ectasia. And then you have a bigger population. So we included 4,280 patients. Patients were enrolled in all these continents. And we had healthy controls, keratoconus, stable post-laser vision correction, and ectasia. The inclusion criteria were healthy patients, as you can see, no ocular surgery, no myopia, no concomitant or previous glaucoma or hypotonic therapies. And the Belin-Ambrosio of less than 1.6. Keratoconus were clear keratoconus with no previous surgery, and stable laser vision correction were the same as before. We use the statistical analysis to do the same. So if you have an abnormal patient, or you think that is abnormal, we use the CDI to separate normal from everything else, because what I told you before is that if you remember, the CDI is abnormal also in laser vision correction. So it was a very good index to start. Then we created a second step that is called CDI step 2 to tell you, we think that this patient had laser vision correction. Can you confirm? And if that is the case, then you use the CDI-LVC. But then let's go to clinical practice. I want to skip the statistical analysis. The sensitivity was very high in all of them. Just wanted to show you this. Sorry. This is using the CDI to separate normal patient from keratoconus and post-LVC. You can see that is more than 90% in training and validation data set. Then you have the step 2, that is the one that will help you to tell you, we think that this patient had laser vision correction. And you can see that the sensitivity and specificity is very good. But you have to remember that this is not needed if you do know the diagnosis. So we need to see the clinical practice. Let me go further because it's much easier. Okay, so you can see from the right that this is a keratoconus. CBI is 0.99, BED is 10, TBI is 1. Very simple. And the Vinci-Guerra screening report will show you CBI is 0.99. Very simple case. If you're used to the curves, you're used to this. This is a stable LVC. This is what you get in the ARV. You get post-laser vision correction recognized. Please confirm. The patient had PRK, LASIK, SMILE. The patient had laser vision correction, but I don't know which surgery, or no laser vision correction. So do not worry if you do not know which surgery it is, because the CDI-LVC works as good as. So if you click, what it happens is that you get the CDI-LVC. The cutoff is 0.5 or 0.2. I think that 0.2 is better as a cutoff than 0.5, even if you will have a slightly more patient that will be positive, but I use 0.2. You can see that the BED and the TBI are grayed out. Why? Because post-LVC, you should not use this. CDI-LVC, and you get the same in the Vinci-Guerra screening report. You get this warning, please confirm, and then you get the CDI-LVC. This is an ectasia. You still get the warning. Warning. Tell me if this patient had surgery. You say yes. CDI-LVC is 0.91. Same thing in the Vinci-Guerra screening report, 0.91. So I want to stop, but I want to speak just one more second, and I want to explain you how important I think this is. It is the first time that we have an index that is able to separate stable laser vision correction from ectasia. With just an air puff, you do not need tomography. Obviously, I'm not telling you to bin your tomographer because you do need the tomographer, but the CDI-LVC is just done with biomechanics. You do not need the pentagram, and is able to give you a sensitivity and specificity of more than 90% with just an air puff. Thank you.
Thank you, Dr. Vinci-Guerra, for your talk, for both your talks, in fact, which gave us insights into so many new things. I would now request Dr. Rohit Shetty to give his talk, and then we can take the questions again. Rohit needs no introduction. Rohit, can we have your talk, please, on the cellular levels?
Can you hear me?
Yes, yes. Biomechanics from cellular and structural level.
Okay. Thank you, Namrata ma'am, AIOS, Professor Tityal sir, Dr. Maipal sir, and two good friends. It's nice to see both of you from on the other side. Usually we keep meeting in the different forums, and I'm happy that I worked with both the groups. It's been wonderful learning experience and wonderful talk, Ricardo. My talk today is understanding biomechanics from cellular and structural level. I'm not going into what has already been discussed. I know financial interest, but this is very important, which I think all of us will be wondering: how safe is aerosols in the post-COVID era? One is that you're talking about non-contact tonometry. So all that we spoke about as the biomechanical tool involves non-contact tonometry. So what we did was we started this very exciting experiment with a group of engineering scientists. We call it as the APPEAR study. APPEAR is Aerosol Projectile Prediction Experimental Applied Research. Everything in ophthalmology today works on aerosols and how aerosols are. This is a very important video because everybody has been saying that do not use non-contact tonometry because there are all anecdotal reports, some hear and say reports. So we build this experimental model. We use very, very high-end cameras. We use laser spectrography. And this is the same, Ricardo, is the same place where C.V. Raman worked, and he built his Raman effect in the same laboratories. So I think Raman effect is use of Raman's work is virtually in every domain of optics today. So these images you see is a non-contact tonometry, and this is the whole setup we had to do to get those high-end images. We are looking at close to 5,000 to 20,000 frame per second. I just spoke to Abhijit, and he said your DSR camera gives you 60, maximum 60, or your best phones can give up to around 800 or 900 frames per second. That means this goes at beyond very, very high level of sync. Now look at this image. This is a non-contact tonometry. Let's see if there's an aerosol. After say 30, 40 attempts, you can see that one baby drop flying off. Again, it comes, I think, if you can see that one baby drop, and that too after you put a lubricant. So, and today we repeated this again. Sorry. Today we repeated this again, and this is again a very fast image. You can see here. Hardly, you can see the cornea being deformed on a non-contact tonometry, but you see no aerosols at all. So we have to really go and figure out what we've been talking about aerosols as a source of aerosol spread, NCT as a source of aerosol spread. We have to come out with experiments which actually disproves some mythical things which we have in our mind. I'm not saying that we are disproved it here, but with the most best fastest cameras, you don't see aerosols. This is important. This is good news for a lot of us, because the biomechanics also uses the same principle of air and how the aerosol. So a lot of us were not using the biomechanics because we were worried about aerosol, and these images actually tell us what we want to see. Now, coming back to my topic, I divided into 3 talks of refractive keratoconus and what is future. In refractive surgery, you have 3 things. One is what you see as a clinical picture, what you topography, and biomechanics. This has been beautifully covered by my previous speaker, but this is where the whole question is. What is elusive? How do you combine all this? I'm sure we'll have a discussion with Namrata ma'am and Professor Tityal sir about sometimes, you know, your topography says something, your biomechanics says something. Now, what do we do? My question to Ricardo later is, how do we actually analyze when all the 3 are not speaking the same language? We have all the 3 things, you know, we have Professor Renato has shown. Now, which is a true picture? And what is this gap is what we want to study. So my talk today in the next 6 to 7 minutes is about filling this gap and trying to have a discussion after that, which I'm sure all the audience today are keen to know. How do you fill in when there are few things which are not following a trend? So what I did was, this is something which already been discussed. I used the different imaging. I give credit to Abhijit Sinha. Both Ricardo and Dr. Ambrosio has worked with him. He built this imaging system to look at the collagen. These are pixelated images of collagen reflectivity using the polarization. And this has been my domain, how the molecular structure match. What I try to do is, if I combine all the 3, what picture am I getting? So that probably would make me understand. One is your tomography, one is actually studying your collagen, and the third one is actually doing something similar to your histopathological examination and seeing how your collagen is. And that is what your biomechanics is at the end of it. So what we did was, this is something which was built in-house with the help from University of Vienna. It works on the polarization sensitivity. You have a imaging resolution of around 2 to 2.5 microns is what we are seeing. That's one of the best, finest resolution of OCT commercially available. And this is a work by Keith Meek, and show how the collagen are. You can see that the stronger here, different, it's like a pillars, and the center is completely different. And that's how the collagen is. And we were able to see the same kind of picture when we actually do the polarization sensitive OCT of the collagen structure. So, and this is a retardation map of how the collagen is oriented. So what happened was, we started looking at everything in a different way now. For example, we have a topography, we have the polarization OCT, which looks at the collagen, and we have the indices. Now, this patient has a small area of weakness here. I'm sure there's a difference of 1.5 diopters of superior inferior. And what happens is, some of your indices are still showing normal. This is something which I want to ask Ricardo. Why is the indices showing normal when you see that there is some amount of changes here? And this is where the confusion for the clinician is. So when we did a PSOCT, the polarization sensitive OCT, you can see that that collagen in that zone matches to this area. There's some amount of degradation. You can match it with this and this. So that means there's some degradation happening, but maybe it's not picking up. And this is something, and this compared to how a normal PSOCT is. And here also what you see is that this is very interesting. Your topography looks normal, but look at this here. Your CDI is abnormal, your TBI is abnormal, and your bad D is in the center. So what's interesting in this picture is the whole of cornea is actually not showing good images of collagen. The collagen is poor. This is where I think my talk comes into, where you're combining two things and trying to understand what happens. This is what Namrata ma'am can be used for discussion. And this is 99% of the questions who are using this technologies. Why does indices sometimes don't match to what you're seeing on your topography? That's because the collagen is completely different. And this is good news for Ricardo, because your CBI is showing abnormality, even though your topography is showing is normal. Because I think the collagen itself is completely abnormal out here, which is proven by the PSOCT picture. And this is the typical thing when you have multiple combination. I'll use this for the discussion, because this is what I think a lot of questions will come. Why sometimes there are multiple permutation and combination of this. And when I use the polarization OCT, it more or less matched to whatever Ricardo was saying. The polarization actually matches to collagen, and your indices are all looking only at the collagen synthesis. So that means there is confusion, but if you really look deeper, you'll probably find an answer. For example, let's look at these cases. Not something great topography. There is some amount of skimming. You can see that some bad D is changing. There is a bad D changes, some TBI, and sometimes even these things are showing as normal. But when you look at your collagen, you see that there is a loss of signal from these zones out here. There's a lot of, and only the central looks healthy because a lot of zones don't match up. So Ricardo has shown this, that is a beautiful software which tells us when the cornea is becoming thicker. Now, the question is it really becoming thicker or stronger, sorry, or is it just a mathematical change? So what we did was the same patient, we did polarization sensitive OCT of pre-op. You can see that the collagen is poor. And the post-op, you can see that there's a huge lot of changes which has happened here. We even did a topo-guided treatment, but you can see that the collagen is much different from what it was on the pre-op. And the same patient actually was showing stiffer on this. So that means whatever he showed as the cornea becomes stronger is actually proved by the collagen changes out here. So how do we move forward? What are the future technology, future things? For example, the same patient here. One of the best ways to study, we thought, was taking the smile lenticule. Because when you take out a smile lenticule, you actually get a tissue. So what we did in this patient was basically the same patient who had a poor collagen on the OCT, and your indices were also abnormal and they were showing difference. That patient, we did a smile extra on it, but we had the lenticule. And when we took the lenticule is like a pen drive for us, for a scientist, because you plug the pen drive, you get virtually everything you want. So what we did was we started looking at collagens and we started looking at multiple things. So what happens was in this patient who had a lower biomechanics, you can see that his lysyl oxidase level was good, but his collagen was also not as good as it should be. So that means that what the indices was showing was kind of matching to what the patient actually had structurally. So that means even though there is confusion, I'm sure this debate will go on. There is a lot of truth in what the machine is giving. Only thing is our understanding has to become more advanced. And this is the same patient who underwent the smile surgery. We always, this lenticule we can study. And this is the most important thing for us, because virtually you can get everything out of it. And we did an extra. You could see that by doing an extra on this patient, it actually became stronger. So I believe that there is some role of extra, especially in a smile patient. And you can see that in this patient, the there is a different level of each patient's lenticule shows different thing. For example, here the collagen and the LOX levels are completely different, and especially in this patient's, there's very low levels, and this matches with your bad D. And even though the topography is normal, it matches with your parameters. So that means that when I combine all the three together, your imaging of collagen, your topography, your indices, and your lenticule, I think a picture emerges. So that I'm not saying that everybody should do this, but what happens is we can give a suggestion that this is why this is how it is. And finally, what based on future, we did some experiment about genes which can cause ectasia between LASIK and SMILE. And this was an experiment on donor eyes, and we found that the genes which works on healing with LASIK is completely different from what happens in SMILE. So that is the reason your SMILE-driven ectasias and the LASIK-driven ectasias, post-LASIK ectasias, do not always match in the same way. They're completely different because you're genetically, these two are, this is all original work and we're just about to write this up. This is the gene which is there in LASIK, and this is the gene which is there in a SMILE. That means that when you get an ectasia in SMILE, which is completely different and not following a pattern, you have to understand that the genetic way of ectasia in SMILE is completely different from what you see in a LASIK. And LOX is one of them, and in LASIK it was the nerves. So these two things, what I mentioned, and these two have a huge implication in understanding the biomechanics also, because there's a huge genetic component of how the collagen stroma is structured. And if you're doing a SMILE or a LASIK, it's going to be completely different. It's completely a different subject altogether, and we may need a long time to discuss, but I'll be open to any questions on this particular subject. To sum up, under biomechanics should never be looked at it from one dimension. If you have to look at biomechanics at one dimension, you'll always have more confusion. I think it has to be looked at it at multiple levels and then integrate it and probably discuss about it. We are working on a differential corvis where we look at different zones. Brilliant microscopy is one, and you have to bring in biomarkers at some point of time, hopefully, which will help us to understand this better. Thank you.
Thank you, Rohit. I think that was a superb presentation where you've tried to link everything together. And I think that will be the way to go in future also. And I would completely agree with you that sometimes after laser vision correction, what TBI you expect is, it's totally off way, it is not on the, and I would like Dr. Ricardo also to react to it, because after LVC, laser vision correction, the TBI values are not pretty much, what they should be. They tend to be little erratic. So would you like to comment on that as well?
Yes, so thank you very much for this question. So the CBI and the TBI after laser vision correction must be abnormal, or all the time you should expect them to be abnormal. The reason why we created the CDI-LVC is for this, because it's the only way to know if your cornea is stable or not, rather than following up the patient. So the CBI and the TBI after surgery are not reliable because they're not made to help you after refractive surgery.
I have a question, Ricardo, for you. I mean, I'm sure Professor Maipal would also be asking this question, is why do you, there are two values which is there. I'm sure the CBI is built by you and your team, and TBI is from the Oculus and team. So there are times both of them don't speak the same language. Now, what do you do with this? Because medico-legally, if you have a indices, and if I don't use it, at some point of time, somebody is going to ask it. If I don't have, it's not a standard of care to have a biomechanical tool anywhere in the world. But if
very true. Well, first of all, it's important to say that, well, CBI, I'm the first author in that article, but in the TBI, I'm still there. So it's part of the same group. It's just that Renato was leading that paper. It's a difficult question in a way, but for me, most of the time it's very easy to explain. I am extremely cautious with patients that are doing refractive surgery. And the reason is the following. I think that patients that are doing refractive surgery are by definition healthy, by definition. So we are improving their quality of life. So most of the time, if I have a patient that I have a significant doubt, which means that I have a TBI that is really abnormal or a CDI that is really abnormal, I would avoid doing a surgery on the cornea. And I maybe go intraocular. If instead is a borderline, that is completely different. Because if you remember, in some, I'm sure that I showed you this in the last meeting. So the CDI and the TBI are created in the same way. So they are created with a logarithmic curve, which means that in the middle, the cases are very unlikely to stay. So if you have a case that you will have a CDI of 0.3, you might have a CDI of 0.3 one time, and the following time it might be 0.8 or 0. So it means that it's really in the middle. What I do, if it is borderline, I just see the patient back. So for example, I had a patient, and that is my best friend. He had ICL in the end, so that was not an issue for me because he's very high myopic, but I was worried because his CDI was borderline. I followed him up, and his CDI after that measurement has always been normal.
So what we did was all the patients who are undergoing SMILE is a great opportunity to collect their lenticules. And
yes, I'm very jealous of that. Very jealous.
So that, we started looking at that, and we found that there are times what you and Renato are saying is right, even though the machine says it, your topography says it as normal. Because what we found in many of the cases were that the patient had a very low level of collagen, and they had very low level of locks, and the patient topography was perfectly all right. But the biomechanical parameters, both the CBI, TBI was picking up. And sometimes if it's a very localized change on your topography, for some reason, the CBI was not picking it up, but the TBI was picking it up as abnormal. And the same patient underwent a SMILE extra or a PRK, and we took the epithelium or the lenticule. And when we analyzed it, we found that the patient did have a lower level of collagen 1, 4, and locks. That means that even a localized areas was not picking up well sometimes on CBI, but combination of this was picking up better. So this is something which I want to bring in, that if you will a localized change not be very indices specific, if you have a very small change compared to a tomography and a biomechanics.
Well, first of all, you know that I really love your work, because I think that what you do, and since many years, is really bringing forward so many important aspects. It is also important to remember that the Corvis is evaluating only the center. It's a central line. So obviously, if you have a very, very localized change, it might not be picked up by the Corvis. So that is a limitation of the Corvis. And this is also because, for example, we have done asymmetric fixation at the same time. There is talks about doing measurement that will evaluate superior and inferior corneas, but it is true. I mean, the CDI and the TBI are not perfect. You will have some cases that they will not be diagnosed. You will still have false positive and false negatives. It's just another tool that is quite good to help us.
Also, when we try to do, 2 or 3 readings for the same patient, same eye, they'll be different. Yeah. Also, at various exam points, also they would be, different and not the same. So I think it also picks up from where, at what point in time you've done it, or and I think it's more so for the laser vision correction and less so for the keratoconus cases. I mean, it's more, it picks up, it's more reliable for the keratoconus cases, but less so for the laser vision correction.
Are you talking about the CDI-LVC?
Yeah.
So the new index?
Yeah. No, okay. Not the new index. No, not the new one.
But no, because the old index is not done for laser vision correction, so it will be all over the place. Just disregard the CDI after laser vision correction. The update with the new CDI-LVCs for free for every user. So just ask for to have the software is absolutely free, and it's already available.
So what happens is many times if your intraocular pressure changes by 1 or 2 millimeters of mercury, your CBI will also change. And so what happens is if you make the patient walk around and come back after some time, and the patient has to, if he has had half a liter water, even that could everything could change. Your hydration could change. So just a 2 millimeter of mercury could change your CBI completely.
But are we talking about pre-surgery? Because
just to add to that, actually, a lot of surgeons are terribly confused as to how much of influencing factor should CBI, TBI, etc. be, because the repeatability is not that excellent, and CBI, TBI often don't talk to each other, and they don't talk to the pentacam. So actually, there is a lot of confusion, because if we go exactly by this, I think we'll be rejecting about 40% of our cases if just one parameter is off and things like that. And we know that the incidence of ectasia is not that high, even if you're doing a blade LASIK now with the thinner flaps. So actually, and now I don't know whether, like Rohit is adding about the analysis of the collagen as to how sensitive that is, or how much is strong the correlation of that is. He said there could be a correlation, there is some correlation, but how strong is that correlation with the indices on the corvis? So actually, it's a Pandora's box. There are more questions that have arisen out of the biomechanics than actually the answers that we have got. Until, of course, there are a clear-cut deviation and the topography and the corvis findings match. So could you just, for a normal ophthalmologist who may not be as deeply knowing all the nuances, because you people know it much better, so to make it more user friendly, that's what I'm trying to say, that because you don't have that kind of a time and effort that everybody can put in to get to the answer.
Dr. Renato, would you like to comment on this?
Well, it's good to see you all doing this discussion, and I'm learning, and I have a very good idea. Jorge, you have the Lenticule bank from Smile, and I suggest you may look at your pre-op database and look at the TBI and the SA1 and the parameters from the Corvis and Pentacam, and try to do some correlation with, I know that lenticules are in the bank, so you can go there and get the lenticle and do the testing, and think about a study that would correlate the data from your lenticles and the pre-op, and eventually mitigate that with the result and the clinical result. And the second question is, of course, the lenticle are great, but we want to have something that is not invasive. You don't need to remove tissue from the cornea. How far are we from a genetic blood test, or do some genetic swab from your mouth and get some DNA and look at the DNA of the patient and get a screening for ectasia risk or keratoconus risk? What's your opinion about it?
I think if I answer your first question, I already presented that today, the data, and I can send you my presentation to you. But the second question is, I mean, that's the way to go to correlate, and that would answer what Professor Maipal sir said, that if you want to have a clear idea of where it works and where you not, you should have a proof that why is it still showing normal when everything is abnormal. That means the topography may be lying, but your structure may be telling the truth. For a simple ophthalmologist, from a point of view of using the biomechanics, if I take the liberty to answer this, Professor Maipal sir, what I would say is, at this point of time, biomechanics is not a simple mathematical value where you can just make an assumption based on what it is. If you understand, you will have to spend some time at being with somebody who is, if you really want to use it in your practice, It is very difficult. I think all of us here would agree that very difficult to make a biomechanics understand using a PowerPoint, or it has to be done with experience. And if you feel that you don't want to get into that and you just don't have time to get into it, so I would suggest that you would wait, learn from somebody, and then get into that picture. Because if you are getting into something very half-heartedly, without proper knowledge, it's like going into a COVID ICU without PPE. So you just have to pray that you come out of it safely. But I personally believe that biomechanics is it's a specialty, and it has to give it due respect. Because you may end up doing a surgery just because the value is normal. If you end up not doing a surgery because the value is abnormal, and both, according to me, is wrong. So I feel that at this point of time, my take-home point is that do not go by a single value. It cannot replace a topography. It is part and parcel of a topography, and but it's fun because you can do a lot of things on this. For example, Ricardo mentioned that now the new thing is about the cornea being stiffer or non-stiffer. It's a fantastic software. I think it really helps us to understand how the collagen is changing. The biomechanics is completely changing. It is not what it used to be many years back. New software have been added, and I think it's going to be the future. But I request everybody who is interested to spend some time.
Yeah, but not everybody is going to do PhDs like you have done.
No, sir, no, you don't need a PhD, but I'm saying that,
So basically what sir is saying is that is there a more practical way of telling people as of now, wherever biomechanics is, what should be the approach for laser vision correction and for collagen cross-linking?
Can I just add one thing? Because I think it's critical to, regardless of whether we want to go in very much details about how the indexes are created and artificial intelligence, what we do need to know is at least how the index change between healthy and normal patient. So for example, if you would use the CDI or the TBI after refractive surgery, you will be very disappointed because they are not created for this. If you use the CDI and the TBI to see if a patient is getting worse or if it is progressing, you will be very disappointed. If you have a CDI or TBI that is borderline and you ask the patient to come back in the same day, you will be disappointed at the same time, because this is how the index are created. They are created with a logarithmic curve. So if they are in the yellow line, you cannot make a decision that day unless you are very expert. And for example, maybe you use epithelial maps and you say, well, this is borderline, but I have the epithelial maps and I'm happy to make a decision. The best thing is just to wait, because patient that will be borderline, real borderline, so maybe 0.3 of CBI or 0.35 of TBI, they will be very few. So if these patients will just wait, I think that CBI and TBI can help you rather than making your life more complex.
Mm-hmm. Dr. Renato,
one question for panel here, because large number of refractive surgeons, or a majority of them, may not have access to a Corvis or a biomechanical assessment. So how should they proceed based on topography? Should they refer patient with abnormal topography for these analysis, or there should be some other way for a general ophthalmologist practicing refractive surgery?
Dr. Renato, you want to take that?
Dr. Renato, you want to take that?
I think that's a very good question, and it goes back to the philosophical message that I try to give to you, which is you have to know what you have in terms of the diagnostic tools and understand ectasia as a complication and understand the risk of ectasia. So it goes back to how much of risk are you willing to take? And we can go back to the question, what is the minimum requirement for exams before refractive surgery? And I remember my past father who did refractive surgery without topography in the times of radiokeratotomy. And if I would say that would be wrong, I will be going against my most basic nature. So today in 2020, we have to think what we have available in your area for doing the best work as possible for your patient. And it means that if you don't have all the fancy tools, and eventually the fancy tools are not perfect, as we just saw in the discussion, we are in a revolution in evolution. I just saw a case in CareNet. They posted a patient with high myopia and relatively irregular cornea on the pentacam with a yellow D or an Art Max that is lower than 400. I would say that's the best case for doing a phakic IOL. So the level of cornea surgery that you are going to do is going to be more if you have more data and more experience. But don't be a hero in refractive surgery. I love this sentence. And if you have questions, if you should do or not, you should not hesitate in saying the best is not doing LASIK. And eventually, if you consider, you can go for surface ablation, which has a lower biomechanical impact than LASIK, and then SMILE. SMILE is a kind in between, and do the best for the patient. And sometimes telling the patient not to do anything and come back in a year is a very wise decision. When I did my training, there was only curvature from topography and central corneal thickness from ultrasound. And I remember Steve Wilson telling many patients, come back in a year, let's see if you are stable. And if you are stable, we can go ahead and do your LASIK procedure. And that's a wise thing to do. So consider what you have and think about the tools you have as the best way to understand your patient and do the best decision to help them. Thank you for your question.
Is there any study anywhere which compares the incidence of post-SMILE or post-LASIK ectasia done with a similar kind of a flap and a similar kind of a machine with the use of Corvis and without the use of Corvis? That means the person just has 30,000 cases like was presented, 30,000 cases where only pentacam was done and a LASIK was done versus another 30,000 cases where both Corvis and the pentacam was done. Does it really add realistic value in practice? Is there any such study, or maybe any one of you researchers can go on to this study retrospectively and see that these patients, because of the TBI, CBI being abnormal, but with the topography, has it really made any difference in the incidence of ectasia? Or is it just an expensive tool, a fancy tool that you have to buy and keep in your practice because other people have bought it?
Well, I see your thinking, your linear understanding. It's very much into the same direction as I have, and we have done a few studies look at the difference between the impact from surgery between LASIK and SMILE, and there's a lot of scatter, but the trend is to say that SMILE has a little lower biomechanical impact than LASIK. If you go to the finite element modeling, you kind of having a same conclusion, and I'm sure Dr. Shetty has a lot of experience with his work with Abhijit Cynthia Roy on this area. But looking at the question that you made the point on, is it a very expensive machine? Should it worth or not? It's something that every refractive surgeon should think about for their own purposes and what they are having in terms of results and how they want to be in the future. Early adopters would adopt to things that are not going to be very good in 5 years. They will not last for more than just a little buzz. But in terms of the integration of data, I would say that tomography and biomechanics today, looking at ROC curves, accuracy, these are studies that look at clinical keratoconus and normal patients. You see an advantage with a significant ROC curve. That was a recent publication that we had just looking at tomography pentacam, and we look at curvature data, we look at pentacam with tomography data, including the PRFI, which is a pentacam random forest index, and then with biomechanics, you can get better accuracy even for clinical keratoconus, not only for the normal topography eyes. which are not clear what if they are truly abnormal or not. We are just looking at patients that are looking normal topography from patients that have very asymmetric ectasia with disease in the fellow eye that is detected. And these patients, they may be Fru's disease or normal topographies from normal patients from unilateral ectasia cases. So only longitudinal follow-up studies will answer to many of these questions, but we are really pretty much in an evolution in this regard.
Rohit, you wanted to say something?
Sir, I just want to add to what we did was, and what you are trying to say is that if you do a same amount of tissue ablation with the same kind of a biomechanics, if you do a smile versus a LASIK, what would happen to them on a longitudinal way?
No. That was not my question. My question was that before we purchased Corvus, and we followed strict pentacam guidelines for, say, smile or LASIK. And after we bought the Corvus, or after Corvus has come, has there been a reduction in the incidence of post-LASIK ectasia, or it is still the same? Has it really added in reducing the complication rate? Has it made the outcomes better in reducing the ectasia? Yeah, Ricardo, you wanted to say something, or Rohit? Ricardo?
I think that I will reply with the same answer that I give to people who are using LASIK extra. So to be able to see a significant difference between LASIK and LASIK extra, which you need an incredible amount of patients. So we are talking about tens of thousands of patients to see a 0.05 of difference. So it's almost impossible to show a difference between LASIK extra and LASIK because the amount of patients that are needed. So it will be even more complex and even more patients will be needed to show you this particular evidence. But what I think it somehow replies partially, obviously, to your answer is what Renato is saying. So if you are able to diagnose significantly better keratoconus with biomechanics rather than tomography alone, it means that somehow is able to tell you when a cornea is suspicious in a more accurate way compared to tomography alone. But that is not, doing the work instead of us. Obviously, if you are a very experienced surgeon, as I'm sure you are, you will be able to pick 99% of the cases just with tomography. I'm sure of that. But maybe there will be one case in which biomechanics will help you as a professor with a lot of knowledge. But if you think about, what we have is for everybody, not for only people with an enormous experience. So I think that in general, having something that is significantly better in diagnosing ectasia is an add-on. Whether this is significantly important for you, that is something that everybody has to see.
I think it's still worth to see to listen to Dr. Shetty about his work on finite element modeling in LASIK and SMILE.
Yeah. So if I answer Professor Maipal's question, sir, what we are trying to do is the biomechanics is helping me to understand, should I go in for a PRK or should I go in for a SMILE extra or should I go in for do nothing? So it really helps in deciding that. I don't believe in LASIK extra because you cut a flap, it's gone. But SMILE extra still is holding on well because it's still, your biomechanics is still maintained. The second question is, what really helps me here is that if you're doing a SMILE and LASIK, the SMILE and LASIK have two different genes completely. The healing genes is different. The genetics is different. So in the SMILE, the genes which cause fibrosis is completely not there. So the ectasia, what you get is completely driven by a different mechanism compared to an LASIK where you have a fibrosis gene. Why is it important is, if you make a mistake of biomechanics being lower in a SMILE patient, there's a 99% chance you'll get a ectasia in 5 years time, 5 or 6 years. It's a slow ectasia because there is nothing to create a fibrosis there compared to LASIK, which I feel is a controlled scar, which actually holds, even though there's a flap which is cut, which holds the eye. That's why patients done 20 years back LASIK without topography is still holding on, because there is a scar there, which is a fibrotic thing there. So at this point of time, if somebody wants to buy a Corvus tomorrow, the way I am using Corvus is, it helps me first, should I do a PRK or should I do a LASIK or should I do a smile? If I'm doing a smile on a poorer biomechanics, then I combine it with a smile extra because it gives me strength. And Sri Ganesh's Sri Ganesh sir papers talks about smile extra has more, even in a suspicious case, is 3 or 4 years data shows much stability. So this is how I would approach if I had to buy this machine fresh, and it helps me to decide. I'm not losing out on patient. I'm actually building and trying to triage them into different ways. Now I'm trying to work on where I can fit this patient based on biomechanics alone. Because if you have topography, you have only two things here: whether you do it or you don't do it. Here you actually get at least 2 or 3 ways of triaging.
Can I say something? So based on whatever discussion we had and whatever presentations we had, do we get a message that if we have a normal topography, normal pentacam, but a bit abnormal biomechanical index, so do we have to wait for that patient and keep the patient under observation rather than going ahead and doing refractive surgery, corneal refractive surgery?
It depends. It depends on many other factors, but I would say it's hard to make a simple rule for you in this regard, just with the data that you just theoretically presenting. But I would say it's possible to have a normal topography, normal thickness, normal tomography, and develop ectasia after LASIK. We have that in the literature. And it's also possible today to see this normal, and abnormal TBI and CDI. And these are the cases that we have to look into the exam and try to understand what's going on. I believe that epithelial thickness helps. That's pretty much what Shadi just mentioned. It's you have a normal topography but abnormal structure. What's going on in this case? Maybe the epithelium is doing a very good job to still make that cornea regular and the optics is still good. But if you go in a more complex domain of shape and optics and everything characterization, you may identify the susceptibility for that cornea to be unstable. And then you have to think about what the patient has, what the patient needs, and how you're going to approach. Considering age, for example, I can go just for a phakic IOL or even surface ablation. And eventually that will be a good idea also to say, let's wait for 6 months and see how it's going. And it's very much another tool for you to make a decision in a more conscious way to help the patient better, as best as possible.
I think there is one question which has come up in borderline cases. Is surface ablation a good option? And has any of the panelists seen a case of ectasia which is detected following surface ablation?
Well, I can reply that for sure we have seen cases of ectasia after surface ablation. Many, not as many as LASIK, but we did see. What about you, Renato?
Yes, we have seen cases after surface ablation. The message that surface ablation is safer in terms of weakening procedure, it weakens less than SMILE and LASIK for sure. And eventually it can even be a good thing because it would give you some healing, and this healing may be like a cross-linking type of effect. However, surface ablation, there is a very good paper from France, from Dr. Malaquais in ophthalmology, that a patient with a relatively normal topography, young patient, developed PRK, ectasia without risk factors. But if you see his topography is a kind of abnormal topography, and that patient may be likely a patient that would develop keratoconus with or without any procedure. When I think about ectasia cases or suspects or susceptible and PRK, I remember Dr. Tamayo. Dr. Tamayo from Colombia, I follow his rules on doing surface ablation in patients with keratoconus. that are going to be stable with custom surface ablation, and he has a huge history of and experience with that since the early days of customization with a cap method that he developed with the topography and a broad beam laser for doing customization in those cases. If you have not a thin cornea, not a young patient, not a too high level of correction, so if everything is kind of moderate, we have these rules to have stability and surface ablation in patients with keratoconus. But you have to also consider that there is a lion and a cat, and 95% of the genes are the same. But of course, they are different. And if you pet the cat and if you pet the lion in the same way, you may be in huge trouble just considering the 95% of similarity. So refractive surgery for elective procedure and therapeutic procedures for keratoconus are similar in many ways, many times, but they should not be the same thing.
Any of the speakers, would you wish to say as to what is the status just now on the thought process of taking out lenticules in smile from a deeper stroma than a superficial stroma? Is it really something that's standing the test of evidence? That instead of making a 110 flap, you make a 160 flap and do the lenticule extraction from a deeper portion, as Dan Ranstein has been propagating?
You know, I love many of the work that Dan Ranstein, I highly respect. He's a good friend, but I don't think his theoretical cohesive tensile strength model that concludes that PRK impacts more the cornea than smile, with, especially with a thicker cap, is correct. I think the assumption has some objective rationale, but that's where the finite element model by Abhijit Sinteroy just demonstrated that if you go with a cap, you are weakening the cornea more than PRK. My question is, if you do a 130 cap or 160 cap, if there is a big change in the cornea tissue, that's an answer that I'd love to hear from Dr. Shetty's lenticule profile testing, because if you have an anterior cornea lenticule and a little more posterior cornea lenticule mid-stroma, maybe you have different genetic material and characteristics on the cornea for the same cases.
There are two things there. I agree completely with you. One is healing is going to be completely different. How your cornea heals anteriorly and how you go deeper and you take it out is completely different. And second is, I personally feel in the theoretical model, the role of intraocular pressure as you go very deeper and you make a deeper thing, I think that will play a much important role in stabilization. And the third is how the epithelial remodels when you have a thicker versus thinner flaps.
So does it? So it's not something that one should switch over to thicker flaps, thicker caps.
Not something we should jump in right away, sir.
I think there's another question which says that from biomechanics point of view, in very clear terms, which is a better procedure, PRK, smile, or LASIK extra?
Or smile extra.
Or smile extra now added to that list.
Do you want to reply?
Yeah. Yeah.
You know, I'm replying by asking Ricardo, tell your experience as a refractive surgery patient.
Well, well, I had
this is one of the most clever patients you ever can think about. Son of Paolo Vinciguerra, who is also an expert. Just my answer is his response.
Well, well, I had PRK, and I wouldn't have any other procedure in the world. And the real reason is because well, you suffer a lot. It's quite a horrible procedure the days after, but I am quite sure that is the one that is inducing less changes in corneal biomechanics. Because basically what you do is you with LASIK and SMILE, there are quite, let's speak about LASIK and SMILE only. So with LASIK and SMILE, there are quite a few studies that are showing now that PRK is the one that leaves the cornea stronger, then there is probably SMILE and then LASIK. the effect of the extra on LASIK extra is very debated. So there is not even that much evidence that it does make anything. There is evidence that PRK extra does do something. Smile extra is something new. So I don't think that we don't have strong evidence enough to say whether PRK and smile extra, they are similar or not. I think that with the evidence that we have now, most likely PRK will be still the most gentle on the cornea.
Rohit, you want to say something on Smile Extra, because I think you feel that there is a role of Smile Extra.
Yes, when we started looking at, we did a we did a control study where one eye smile and Smile Extra was done, and we looked at the collagen imaging of the patients, and we found that the Smile Extra eye had more stronger collagen layer compared to what we see in a non-Smile Extra. So I feel that for a long time I was not convinced, but when we started looking at these images and when we started looking at them clearly, and also Dr. Sri Ganesh's data is there, which talks about in suspect cases where they did the extra procedures and these patients did not show any signs of ectasia. So I feel that, like Ricardo, I'm 100% that PRK is the way to go. It's the strongest in biomechanics. Second comes to me the Smile Extra, in case you are doubtful about your biomechanics.
Rohit, you're going to do a Smile Extra for all patients, or
No,
only
sir.
those patients where you feel your biomechanics are weaker?
Yes, sir.
What about their refractive stability? Because once you do some sort of cross-linking, the refractive stability might not be as you see in a routine patients.
Sir, I reduce it by if I'm treating any patient less than -2 diopters, there is some amount of cornea becomes compact and some amount of small hyperopic shift it goes to. So if I'm treating less than -2, I just undercorrect by around 0.25 or up to 0.5. But if it's more than -2, that how the cornea becomes compact and that small shift does not really matter, because patients, the smaller the refractive error, the more is your refractive stability. And when we actually measure with these, the new OCT I mentioned, the change in the collagen is just at the interface. I feel it is creating more like a very localized controlled scar. I use the word controlled scarring because I feel that the LASIK is actually doing a controlled scarring at this interface, which you can only see through a confocal microscope, and still you don't see them going into an hyperopic shift.
But I think that titration is something which needs standardization when
Yes.
you're combining cross-linking with the refractive procedure. Because
Yeah.
for refractive procedure, you have to be bang on, and this side or that side is something that would need standardization in future studies also. Renato, we've not heard from you on this.
Yeah, I think, well, I'm not completely against the extra thing, but as you just mentioned, the point is that a lot of extra protocols are out there. They are too fast cross-linking, and we know that cross-linking needs riboflavin and oxygen. And riboflavin and oxygen, they are not going to be pretty much in the sweet spot if you do too much high energy. So you have to understand about it and think about what is the best protocol for doing the extra. When I see the data from John Canalopoulos on extra LASIK for hyperopia, it makes some sense, because maybe that little tiny change may be enough for getting a more stable cornea and possibly for high myopia too. And Smile Extra, in my opinion, is the one that I do. I do extra Smile, but I don't think about extra PRK and extra LASIK. I do Athens protocol, Cretan protocol, Tel Avivian protocol as a therapeutic procedure for keratoconic patients, which is not PRK extra, is a therapeutic, advanced, custom surface ablation along with cross-linking. And usually I don't go higher than 5 minutes with 18 milliwatts. But today I have been moving now to 10 minutes with 9 milliwatts, because I do believe that this will be more effective in terms of creating the cross links in the extracellular matrix of the cornea. But this again is a topic of debate. And the basic point is, are you talking about refractive elective procedures in which you have to have very good predictability for helping the patient, or you're talking about a therapeutic procedure to take a patient that needs a transplant for doing a elective, less invasive procedure as a therapeutic procedure. So those are two different animals, and you have to understand the difference while they are very much similar.
Are there any more questions? I think we've answered all the questions, asked all the questions to our heart's content. If there are any more questions, in a spirit of truly, in the spirit of a master class, sir, Dr. Titial, sir, would you have more questions? Because
So it was a wonderful experience for all of us to
yes,
listen to experts, who have taught us so many things. And we are also working on, some of our patients with now we have Corvis for last 1 year now. Maybe towards the end of another 1 more year, we'll have some data for Indian or a North Indian patients, see how it comes out.
No, but I think the best thing is it is a revolution in evolution. So I
That is
also
true.
use that. So I think the last word has yet to be said, and there are lots and lots of things that need to be actually looked at, and things will come out. So anyway, I think in any case, refractive surgery has become relatively safer ever since we started looking at the posterior float and also reducing the thickness as regards and following the guidelines from increasing it from 250 to maybe 300 residual bed and the PTA and all those things. So I think overall refractive and reducing the amount of ablation, because I distinctly remember when we started, we wouldn't bat an eye even if we had a -14 or something to be done. This is way back in 93, 94. So things have changed. Phakic IOLs, ICLs have come in, and they have offered a very significant, this thing, cross-linking has come in, and even if there is some ectasia, it can be managed well with rings. So I think it's an evolving field, and there are lots and lots of new things that are coming up, and it's all because of researchers like the three eminent speakers that we had who are bringing in more on the table with their research. But overall, I think it's a fantastic, what now, 2.5 hours that we have had almost.
yes.
And
That's what I said. All our questions that we ever wanted to ask have been asked and have been answered also. So that way, we are really thankful to all our speakers. Dr. Renato, thank you so much for that wonderful lecture and for your time in between the clinics. Sorry for shunting you on that. Dr. Ricardo, thank you again for your great lectures and for insights into, biomechanics, which is not understood that well by everybody, but then, when you explain it, it becomes a lot clear. And Rohit, for your futuristic insights into how the biomechanics is going to change, and for all your contributions into it. Thank you, Professor Titial, sir, for being there and for steering the whole webinar, and Dr. Mahipal, sir, for all his guidance, encouragement, and for this first ever AIOS masterclass actually that we did. This was for the first time that we've done a masterclass, and the idea was that everything, even we are, getting educated as panelists, and everything that we wanted to ask was answered. And Rajesh, would you want to say something? And
No, it was actually a very great learning experience, and I guess most of us got the answers of most of the questions, and of course, many more questions will arise as we keep doing these investigations more and more.
Renato and Ricardo and Rohit, all ours, all three
Yeah.
ours, will solve this puzzle of biomechanics, I'm sure, in future.
Rajesh is also an R. So there,
So thank
So it's
you.
not only the answers we got, that these lectures have given us more queries in our mind.
Yes.
Look
Absolutely.
into our future aspects and try to, get some answers from our side also.
and I think you need to thank KLB and
Yes, we would
Yeah,
like to thank
definitely.
our audiovisual team, our staff at the back, Mr. Kripal and Ms. Raki, and very importantly, the KLB team, Mr. Divakar Paul, who's actually coordinated the whole activity, got everybody together on board, And we had decided about this about 10 days ago, and it happened in such a short span of time. In fact, this idea came when Renato came in one webinar only for 5 to 7 minutes, and we just thought that, we should have him for a longer period of time. So thank you, Renato, and thank you everybody for being on board. And we will have more of you in future as well, and I'm sure you would come on the panel again and solve all the unanswered queries that you also have in mind and would have more answers to it. Thank you so much. Thank you, everybody.
Thank you.
Thank you, Mr. Devakar. Thank you.
Thank you.
Thank you.
Namaste.
Good to see you all. Bye-bye.
Thank you. Bye-bye.
Bye. Thank